when a normal cell becomes cancerous, does it develop a marker, a biomarker? Let's metaphorically call that the red triangle. And when I refer to the red triangle, that's what I'm going to be talking about, the marker, the biomarker for cancer. Does the normal cell develop that red marker that says this is cancer? By the early 1960s, the common wisdom was that a tumor-specific material had not been found, and that in fact one would never be found. And for me, that was the gauntlet thrown down and the challenge. Immunology had just come into its own, and the variety of studies had already been done. But there were problems with those studies. There were a problem with the studies because, first, normal and tumor tissue had been taken from different individuals. For example, cancer of the stomach from the cancer patient, normal stomach lining from a patient having a peptic ulcer. And if a difference was found, the question always arose, was that difference a difference between normal and tumor, or the simple difference between two individuals who obviously differ greatly, as we all do, from each other? Secondly, the production of the antibodies to look for the red triangle had only always been done by one technique, which was always inadequate if you're going to interpret data properly, and not too many procedures had been done in looking for the tumor antigens by the antibodies we hoped we would find. To correct these deficiencies, the first thing was to get the tissue, a normal and cancerous tissue, from the same individual. In the German literature, in the German pathology literature, it was known quite clearly that the colon presented that possibility. That wasn't something that they had decided on, but basically they had published. Although bowel cancer spreads rapidly through the circulation and the lymphatic, within the wall of the bowel, it does not spread for more than 4 or 5 centimeters on either side. Because our surgical colleagues have to remove a clean specimen, they usually go well beyond that 5 centimeters, and also it allows them to keep the circulation intact afterward. But what that gave us was normal tissue beyond the 5 centimeters for comparison with the tumor that we were going to look at. And we looked at this by simply saying, if people couldn't find the red triangle, perhaps a rabbit might. Because a rabbit is a superb antibody producer and might be able to find that red triangle, our antigen, in the cancer cell. We did this in 2 ways, both of which are subtractive. We used a technique that had been described by Peter Medawar, Sir Peter Medawar, Nobel laureate, for having demonstrated the phenomenon of immunologic tolerance. 2 mice of different strains transplanted with tissue from the other did not react as adults if it was done in newborn animals. So what we did is take this a bit further. Could we make a rabbit, newborn rabbit, believe that normal colon tissue was self, to which not to react? Now they're subtracting the normal material at the front end. We then immunized the adult rabbit 2 or 3 months later with the cancer tissue in the hope that the rabbit would now see only the red triangle because they would not be able to react to the normal material in the bowel. The second technique was to do the subtraction after the fact, immunizing the rabbit with the whole cancer tissue, allowing the rabbit to make antibody to everything, normal and cancerous, and then neutralizing the antibodies by adding normal tissue to the tube, hoping that only the reactive antibody against the red triangle would remain. To our delight and obviously satisfaction, what we found when we looked with the 2 different anti-sera, the tumor-specific antibody and the colon cancer, was a single band, indicating that in fact there was a red triangle in the colon tumor. And at that moment I knew something that no one else in the world knew, and it was a great feeling. I guess it's why we do research. We went on to look at 5,000 tissues from the pathology lab, from the operating room, normal, cancerous, inflamed, non-inflamed, any pathology we could get, and became the only tissue that contained this marker, this red triangle, were cancers of the digestive system. Then at a seminar that I gave in the Department of Physiology, my home department as an undergraduate, the then chairman of the department, Hank McIntosh, raised the question of why it was that this material was so specific to one embryological organ, the endoderm, the lining of the digestive system, which raised the entire question of why indeed. And from that point of view, then we sampled a variety of tissues from embryos in every organ that we could get, and again found that the only place we could find the red triangle was in the lining and in the tissues of the digestive system before birth. Hence the name, the carcino for cancer, embryonic antigen, or CEA, was applied to the molecule in question. We then published in the Journal of Experimental Medicine. My colleague Sam Friedman, right next to me in that photograph, who was instrumental in allowing these studies to go forward and most helpful in helping in every fashion. We're so excited about these things, and we found that it met with an enormous silence, which was quite surprising at the time, except that now we know very well that key high-intensity papers that are seen by colleagues often leave them quite skeptical about the possibility of the reproducibility of these experiments. So we spent the next months, if you will, funding in mailing anti-sera to anybody who would have them in Canada, the United States, Europe, and Japan. And this is, for example, the return of a slide from our colleagues at the Massachusetts General Hospital, Dr. Zisselbacher and Alpert, saying, it's true, it works. And over time, in fact, we had these returns from virtually everyone who had seen this. So they also said, yes, there is a red triangle in colon and digestive cancer tissues. We found that the CEA molecule sat on the surface of the cancer cell. Then the question came as very simply this. We are clinicians. I was a lot younger when I sat for that sculpture. And Rodin, the thinker, says, what do we do with CEA? We have a triangle. We have finally found the triangle. How do we use it for patients? And that was something we had to start with by developing a radioimmunoassay for CEA, which allows us to measure as little as 1/1000th of a gram of CEA in 1 cc of blood. And by doing this, and ultimately the other studies that came up, it became the first blood test for cancer that was sanctioned by the Food and Drug Administration in the United States and then virtually everywhere else in the world. And to this day remains the most commonly used blood test for cancer that's used in general. Having done the work for blood testing in cancer, what in fact is the current status of CEA testing? First of all, CEA is not tumor specific. It is tumor associated since it's found in small quantities in normal tissue. It's not a screening test for cancer, although some of my colleagues are trying to make that point, and hopefully with time that may become the way in which CEA is used. But in inflammatory conditions where it may rise, it always stays at a plateau. It does not rise upward. But when CEA begins to rise, invariably there is a cancer to be found. And interestingly, not only in digestive system cancers, which we first began to look at, but now we know because of the sensitivity of the techniques that are now in place, we can find CEA in 70% of all human cancers, which we find to be a remarkable phenomenon. Now, what are the major uses of CEA, for example, just in colorectal cancer? Now, from the American Society for Clinical Oncology, they make the point that it's useful as a guide to the preoperative diagnosis and surgical planning and chemotherapy for cancer, quarterly monitoring for a 3-year period. And there's a useful guide for the monitoring and the response to metastatic disease and the therapy of metastatic disease. The National Comprehensive Cancer Network, suggests serial testing for 5 years after removal of the cancer of certain types and stages. The 5-year prognostic study indicates that the preoperative CEA level is a predictor of the subsequent course of the disease and will indicate how long the patient can expect to be cancer-free. The pattern of cancer of the CEA decline indicates again the likelihood of the patient doing well or requiring chemotherapy and second-look surgery. Now, finally, we get to the possibility of having a red triangle that we can attack. So is CEA a therapeutic marker? In 1965, we looked for a red triangle. Now that red triangle is inverted, and we know that there is enormously increased materials to be looked for and found. CEA, like the Jedi, keep coming back. And for those of you who are going to become involved in going forward in this area, may the Force be with you.